We're going to move on to our panel presentation, our next panel, which is going to be led by Dr. Rosenfeld and our healthcare providers. And I think I'm going to let Rich introduce his panelists.
No, that was fantastic. So this is our first panel, and it's about incorporating these principles that we've been speaking about into your practice. And I'll introduce our three participants in just a second. Introducing our panel. Let's see. We have Sandy. Why don't you go first, and I'm going to ask them to just real quickly, a minute or two at most, just say what's their interest in lifestyle medicine, diabetes, and we need the very quick fun fact. Okay, so Sandy, go ahead.
Hi everyone, I'm Sandy. I'm currently an endocrine fellow at Mount Sinai, and after seeing how big of a change lifestyle can make on my patients, it's definitely motivated me to want to continue doing that for my entire career. Yeah, I'm short, so. And just like Michelle was kind of saying, when you realize how much of a difference lifestyle can make, that is 100% what I wanted to do. And I actually got my hands dirty in medical school back at Dartmouth with culinary medicine. So it was actually teaching patients in a teaching kitchen how to make these healthy meals. And that's what really showed me that there's so much more health education that we have to go out and do. And I'm so glad that you guys are all here to help us go forward with that. My fun fact is that I have a community garden, which is a 10 by 20 foot square plot, and I actually made stickers that said Nibble Farms and Residency, and I would give out bags of zucchini and tomatoes to the other residents.
Wow, Dr. McMackin, we've heard from already, but fill in the blanks.
All right, I'm going to skip over my lifestyle interest and diabetes interest because I talked about that. And I'm going to go right to my fun fact. So my fun fact is actually that I get called a lot of different names. And no one seems to be able to pronounce my last name, even though it's phonetic. And so one of my favorite things that I get called is Big Mac. And that's ironic for someone who's recommending plant-based eating, but I'll take it. And I get called other things too, but I'll keep them to myself so I don't persist the problem.
That's a great fun fact. Jonathan?
Thank you. First of all, Jonathan Weber from the Yale School of Medicine on the faculty at the PA program.
Yeah.
Yeah, maybe I'm just not close enough. And like Dr. McMackin, tried to work on that.
That is perfect. Thank you.
I found myself after 10 years in clinical practice wondering why lifestyle medicine was only a top sliver of the recommendations, and then it unveiled into multi-dose medications or multiple medications for treating diabetes. And after 10 years, I couldn't believe, why was I never trained? Where can I get this training? And I think about myself as, again, one of the multidisciplinary caregivers here, and I'm so happy that you are receiving it today that I wish I would have gotten 28 years ago. And that that I feel privileged about sitting with these titans and with all of you. So my fun fact, I am a former ballet dancer. Wow. And danced ballet for about 15 years in my early 20s and mid-30s. And I use that as a way to challenge my students by saying, if you're always in your left brain, you'll never be in your right mind. So I challenge you all to keep that corpus callosum active.
That's awesome.
Well, I've already been introduced, but the fun fact was going to be the running, but I'll give you a different one. So I play accordion and sing. and used to do professional in restaurants, walking around in an Italian restaurant from table to table with my accordion singing, okay? So, interesting. We've all have these dark secrets. I love that. Okay, and you're going to all need to write your fun fact on your name tag so we can see it during the networking session. Real quick intro to diabetes, and then we're going to go through some of the pillars. We've seen a bit about this, but I love this study in general. Just shows the rise, which, and this ends in 2017. I'm sure it's even higher now. And it's interesting that there's a cadre, about 3.5% of U.S. adults who don't even know they have it, but they have it, 11% who have it, and then about 3.5% who are just undiagnosed. So it's huge. And then, as we said before, prediabetes is like another 38% of folks. So it's a big, big deal. Diabetes, if it wasn't, you wouldn't be here listening to this, right? So big deal. We spoke about our guideline a little bit earlier. And actually, Jonathan is on our panel, what we call our guideline development group for this. And this guideline's a little different than other ones out there we start with a relentless focus on quality. Actually, the way we come up with our recommendations, and many of you have seen guidelines that are several hundred pages long with literally dozens, if not 100 or 200 recommendations. We're very parsimonious. We have about 13 or 14 recommendations in this whole guideline, and every one of them is intended to be a quality improvement opportunity. Very pragmatic, that if you do this, you're going to provide better care. So that's what we focus on. We develop what are called key action statements, asking people to do something, and then we support it with evidence profiles. So, for the structure of this panel, what I'll be doing is for several of our main statements, I'll show you the statement and the profile, and then I'm going to torture our three participants here on elaborating on, some of those aspects. So these are draft things that are in progress with ACLM. We have a very lovely draft of the guideline that's getting some review now. And as I said, probably first quarter 2025, I would expect it to be published. And I think it's going to be great. So this is a typical statement. So physical activity, you should prescribe physical activity with an emphasis on aerobic and muscle strength training, which a lot of you sat down before when Dr. Frates asked you about 2 days a week of strength training. And do it by being fit. Frequency, intensity, time, and type framework with SMART goals. And I won't go through this for time purposes, but what you're seeing here is called an action statement profile. So when we develop a recommendation, we look at the strength of the evidence. How robust is it? Are we convinced that there's a preponderance of benefit in doing what we're asking the doctor or the clinician or the healthcare professional to do, and any value judgments that go into it? These will be in the guideline when published, so I won't go into it here. But here's for the panel. And what I've done is, when we have these statements, we have supporting text. So there's a couple of paragraphs or even sometimes a couple of pages of background going into these statements. And I went through each section and picked out some key words that I thought were good. And we're going to do this lightning round style because I want to get through it. We're the only thing between you and lunch at the moment, which is a horrible thing to be, but it is. So I'd ask our participants to really limit any response, just to 60 seconds. I know that, Sandy, you said physical activity you wanted to speak about, so go speak about something there.
Okay, really quick. I'll speak as fast as a New Yorker. You guys will all understand. But one of the things is that with continuous versus high intensity exercise, there's so many options that patients have. So like Dr. Frates was talking about before, even getting in a 10, 20-minute walk after each meal, it all adds up and helps lower the blood sugars. So one of the big things is that 75% of patients don't even meet the basic exercise requirements at this time. So how can you take someone who's sedentary and suddenly say, I want you to exercise 5 times a week for a half hour? Even I couldn't do that. And so one of the big things that I focus on for my patients is meeting them where they are and starting small. So one of the things that I like to do is standing, taking those standing breaks right after every 30 minutes to an hour, whatever they can do, and especially getting them to walk after meals. Because if you guys think about it, at dinner time, you eat your food and then you're on the couch watching TV, relaxing for the rest of the nights. So that's one of the big things that I like to focus on is start off by walking right after dinner, and especially if you can do after meals, that's even better. But that dinner time one is one that I really like to hit because the A1Cs or the sugars actually go higher after dinner because of melatonin being higher too. So that's a really good spot to start with your patients.
Great information, but it was about a 2 to 3 minutes, 60 seconds. Michelle, do you have anything quick to add on this?
No, because I was literally going to talk about postprandial
okay.
exercise, so we got that.
Simply echoing, connecting with the patient, getting them started with something that they can do, whether it's in their home, whether it's in the office. I've been doing soleus push-ups since I've been up here. Did any of you notice that?
We can
I've
see it.
actually learned about soleus push-ups. You can actually have your patient, during your clinic visit, do soleus push-ups in your office, just to get them
It's a
started.
leg muscle, just
It's
sort of lifting
your
your
calf.
legs up
Lifting
and
your legs
down.
up on your toes, up and down,
Yeah.
up and down, up and down.
It actually reduces hemoglobin A1C.
Simple things, starting small, incremental, progress over perfection.
You got it. As they say, exercise snacks, all right? Little exercise bits there. And make sure you keep in mind there's aerobic, there's strength. You need both. You can't just do the aerobic. And even beyond that, we don't really talk about it, but you need impact. You need something to bang your bones every once in a while, whether it's jumping, jogging, running, because that keeps your bones strong. And then Joanne will be happy, Dr. Katz, if your bones are strong. A corollary to this, and it, was not just to get more activity, but reduce your sedentary time. And they're not mutually exclusive. Yeah, and this is a strong recommendation. As I mentioned before, we had so many systematic reviews, and the evidence is so robust. I've done a lot of guidelines, and I've never seen evidence as robust as for lifestyle interventions. I mean, it's just an orgy of evidence supporting this stuff, but it's not, people don't know it. So, sedentary times, sitting is the new smoking. So, Dr. McMackin, let's start with you here. Anything resonate with you?
I mean, I think that it's really important for people to just be aware of how much they're sitting and just helping them understand that any movement at all, even standing up, is great. One of the things I've worked on with patients is if you are sitting and watching TV, nowadays you might be watching on a channel where there's not commercials because you might be streaming. But if you are watching where there are commercials, standing up during commercials and maybe walking in place during the commercial and then sitting back down if you want to sit back down. But getting into that rhythm of doing that is great.
Yeah. Jonathan?
I tried to ask, we always want to assess, right? Assess where our patients are first. And I think first and foremost, I always try to ask provocative and paradigm shifting questions. the COVID epidemic has really pushed us to be socially isolated. Now we're coming out of it. And what I like to try to do is to ask how many, in my assessments, ask them not only when their meal times are, but how much time do they spend watching television. You know what you could do while you're watching television? So you must be pretty active because you can actually do chair yoga while you're watching television. So again, trying to shift their paradigms and thinking about moving out of the sitting is the new smoking.
Okay, Sandy, I'll get you on the next one. But yeah, so it's like Michael Greger, if you know How Not to Die. If you ever talk to him, he's always on a treadmill when he's on a Zoom call. So I started doing that. You bounce up and down a bit, but you know, so be it. And I have to add that, you know, as far as exercise, I'll never forget at Rachel's request, Atchison, I was with the Brooklyn Borough president years ago. We gave a talk. And someone in the audience asked Eric Adams afterwards, can you build a gym for us? And his response was, what do you mean? We already have one. Really? He says, yeah, it's called a staircase. Mm-hmm. You can go up and down. So you can take breaks and go up and down on the stairs. All right, sleep disorders, this we spoke about. And you really need to ask about this. It's not discussed usually in the context of diabetes, but it's a real issue. And a lot of people have sleep disorders. The evidence for this is robust as far as how better sleep patterns can improve your glycemic control, your diabetes management, and it doesn't take a lot to do. You know, we always have value judgments we outline, and, you know, it's very easy to miss this because people don't talk about it. But we're going to talk about it. So, Sandy, sleep.
As the closest to residency training and being forced to have terrible sleep, I think one of the most important things is maximizing the sleep that you are getting to make it effective too. So just like Dr. Frades was saying, those closeout curtains, getting an eye mask, making sure things are quiet so that you can get the most effective sleep when you're forced to get less than what would be ideal.
Great. Michelle.
Yes, so I think one of the things I love to talk about with patients is their liquid consumption before bedtime. It's amazing how many people don't realize that they're drinking. I mean, I love people being hydrated, but get hydrated earlier in the day and then try to cut yourself off a couple hours before you go to bed. And then people come back the next visit and they're like, I'm actually sleeping through the night. Thank you. So that's one. The other one I love to recommend is to take a morning walk. I'm a huge fan of morning walks for multiple reasons. Number one, you're walking. You're moving your body. Number two, you're actually helping restore your circadian rhythm because you're exposing your cells to sunlight, to your retina to sunlight, and that helps you sleep better.
John.
I'll just add, our computers on our phones, they're fused literally to our faces most of the day.
It's true.
And so Dr. Frades eliminating it 2 hours before, it's difficult to do, but it's something that we have to continually encourage.
Michelle's comment reminds me of, what's his name, Robin Sharma, the 5 a.m. Club. Anybody read that book? It's all about how the most successful people get up and are active at 5 a.m. And part of it is sunlight and light and seeing things. So, no, people don't do that. I do it all. Well, no, I slept late today. I got up at 3:15 this morning and did 9 miles on the treadmill of intervals before coming here. So 5 a.m. is late. I mean, come on. Come on, it's late. And by the way, you can't average out your sleep. You can't, like, catch up on the weekends. It doesn't work. It's kind of like putting your left hand on the burning stovetop, your right hand on a block of ice and saying, gee, on average, I feel pretty good. It doesn't work. You got to get the sleep regularly. You don't want the so-called shift work disorder where you're getting weird sleep. Nutrition. We've spoken about that a bit. And we have 2 statements on nutrition in our guideline, at least for now. One is about prevention. So this is for people with prediabetes, gestational diabetes mellitus. You really want to avoid this progressing to full-blown type 2 diabetes. And this is an old concept, again, going back to the diabetes prevention programs. You can do this, and it's the best time to intervene. So we're very strong on prevention. And there's a number of things we can talk about here. I think I'll start with Sandy, because I know she has a lot of nutrition interests. So in the context of prevention, your thoughts?
So important. Personally, for me, I think this is the biggest thing that will get people feeling their best the fastest too. In essence of time, one of the things I would definitely recommend is one, give up soda. Give up those liquid sugary beverages that add the unnecessary calories and a lot of sugar into people's diets.
Great advice. Dr. McMackin?
I think when I have a patient with prediabetes, I think the first thing I want to help them understand is that they have an amazing opportunity in front of them. Many people think this runs in my family, it's just a matter of time. And so just setting that validation that what they, the foods that they choose to eat can make a huge difference. And I didn't mention before, but we also, this is a wonderful time to assess someone's access to healthy foods and help them receive resources for that.
And you, just to build on this, at your program in health and hospitals, I know I was at the Kings County launch, you have a massive kitchen and a chef, and you're really doing all the good stuff there, right? I think your chef is back there, I saw him. Very important. And you also triggered in my mind this concept of empowerment. I think a big point of lifestyle medicine in general and the interventions is that you are empowering the patient to heal themselves and to take care of themselves, often without drugs. It's one of the most, I think, enlightening and wonderful messages you can give people. Jonathan.
I'll springboard off of that. It's into one of the questions I like to ask my patients is that are you the kind of person who likes to wait to be changed or to change? And directly to Dr. Frady's, one of her main points in the story of her father, do you know, I'll ask them, that you have the ability to change how you are going to age, how you are going to spend probably the rest of your life. You have that choice. And so putting them right back with that initial question, then they're going to want to know why. How does that work and why does that work? Hopefully, they'll take that challenge.
Wow, pique their interest, okay. The second part of nutrition is nutrition for actual individuals who have type 2 diabetes. And we recommend here that the clinician or healthcare provider, figure out, is their patient interested in full remission or more just management, de-escalating their meds, improving things, because it requires a little different approach to do it. We can only find 31 systematic reviews that dealt with this, so there was a paucity of evidence. But it's, and the evidence on this is really incredible. As we mentioned before, it has to do with intensity. So especially for remission, you can't just casually add a cup of beans to your weekly diet and think you're going to put your diabetes in remission. It takes a little more than that. And it is the optimal goal. So thinking about nutrition, we'll go back to Jonathan again. I've been saving. We got to get him up front. Come on. Jonathan, your thoughts on the remission.
I have these pearls that I have collected over the years, and I read a book by Roger Landry, the Live Long and Die Short. The whole idea about compression of morbidity, that we can compress our morbidity to the end of our lives, really, with a lot of these healthy lifestyle choices. So I try to help them with this 70-50 rule, that all the evidence in his book that basically says that 70% of our physical aging, 50% of our cognitive aging can be related to our lifestyle choices. So I try to drive that again back to the patient. You have an incredible power in your choices.
Okay, Sandy.
Going off of Jonathan's numbers, I'm very practical and I like to kind of give my patients and help them find their goals and also help them achieve something that's actually a lifestyle, not just a diet. And so I have an 80-20 rule where 80% of the time you're good. You try to focus on whole foods, eating plant-based, avoiding processed foods, and 20% of the time is a cheat where you can eat that cookie, you can have that chocolate and kind of give in to what you want and what makes you happy so that you also feel like this is something that you can sustain long term.
Michelle?
I want to talk about a 4-letter word, which is carb.
Carb.
We've alluded to this already, but I have found that when I'm talking with my patients who are living with diabetes, it has to be discussed. You have to talk about it. You have to break down because they are getting messages from every single direction. Their family, their friends, their other medical providers. Everyone is talking about don't eat carbs. And so you really have to break this down and help people understand, especially if you're recommending eating more plant-based. So I do that. I'm going to go way over 60 seconds if I talk about it, so I'll just save it for questions later. I think it's really important.
So how many folks in the audience who have encountered either a family member, a patient, somebody with diabetes have encountered the carb phobia? Have you yeah, I mean, it's ubiquitous. And how many of you have been successful in telling the person with carb phobia, it's okay to eat whole grains? A few, maybe 10% of the hands. Yeah, it's a tough sell, I don't know, but we're hoping with our guideline, we're gonna focus a lot on that and give a lot of information to the patients. It's the quality, it's not carbs themselves. It's that fiber for all those short-chain fatty acids and stuff your microbiome is churning out. Let's move to social connections and peer support. So we're asking people that you should emphasize and really advocate and counsel them about the importance of these positive social connections. And there's a few varieties of it. It could be through your peers, through your family members, through other professionals, support groups, and so on. And as usual, a lot of evidence supporting this. We're big on SMART goals throughout the guideline and have a lot of examples of those. So in this context of peer support and social, and Jonathan alluded to COVID, which I think has, added to a bit of a loneliness epidemic out there. We'll start with Dr. McMackin. How do you view this?
I think it's many patients when I ask them about, who's meaningful to you in your life? Who provides you social support? And those folks in the room who are medical providers in our programs know that's part of our template for our initial visit and our follow-up visits. And that's a moment where often people it will become very emotional because either they'll have someone that they really, really care about and then you'll hear about it and you're very moved as well and you want to talk about how can you strengthen and make sure that those bonds stay strong. And then it's also can be emotional when someone tells you that they don't really have anyone and they want to have more social connection. And so, there's different approaches to that. One of the things that I've actually really enjoyed doing is talking, especially for some of my older adults, patients, talking about volunteer work. There's a lot of opportunities to do volunteer work. Some of it can even be virtual if someone doesn't want to, can't or doesn't want to leave their home. So that's a wonderful thing that I have found to work with patients with, and it helps with finding purpose and meaning, which is I kind of bring into this category too.
Sandy, are you officially a Gen Z or a millennial?
I think I'm still a millennial.
Millennial, okay. So give us the millennial perspective on this.
I actually love using the support system to help motivate patients to do things like exercising, eating healthy within their group. And I am a big fan of social media, Instagram, Facebook, to help find that community too. I think a lot of times social media can definitely have negative effects on people, but it can also have a lot of positive ones. So for example, I'm a first-time mom, and the first Facebook group that I joined was Physician Moms, and I found so much support in terms of what I'm trying to get through in finding other people who share that. So using that support system to say, hey, join a group Zumba class or join a cooking class so that you're not just doing one thing, but you're also finding a community who loves to do the same things that you do too.
What happens at Yale?
I have to say, it's incredible because I was stunned. I was actually privileged to be one of the writers of this part of the guidelines, and one of my co-authors is here. And I was stunned by how much I didn't know, how much I've never been trained about how much evidence is out there on positive social connection and the effects. So I'll just lay that groundwork, number one, and then to kind of springboard, if you have any sense of the counterbalance of this is social isolation, loneliness. If you pick up on any of that, one of the teasers in these guidelines is an initial 3-question assessment. You can ask patients, how often do you lack companionship? How often do you feel left out? How often do you feel isolated, socially isolated? Those 3 questions taken from a larger 20-point item question from UCLA loneliness scale is going to be in these guidelines.
Wow, that's great points. And our guideline in general is going to give very practical ways to get baseline assessments of the pillars using validated tools. Very short, quick thing. I mean, physical activity is basically 2 questions. You have well-developed measures like John was alluding to for all the things. So I think it's very important because it's one thing to tell you to do this, it's another thing to make it easy. So we're going to hopefully make it easy. Psychological interventions. There's a lot of stuff out there, and it's more prevalent in individuals with diabetes, not just diabetes distress, which is well known, but other anxiety disorders, mood affective disorders, which can be very easily overlooked. We do have someone representing the American Psychiatric Association on our guideline panel who's been very helpful for this. And the value judgment here, I think, is interesting that this is really important, but people don't think about it. When you deal with lifestyle interventions for diabetes, most guidelines and folks don't go much beyond nutrition and maybe a little bit about your exercise or activity, and then it all, sort of becomes a little bit random. So for this psychological intervention, all sorts of possibilities here. Let's reverse the order. So, Jonathan, I don't want to stress you out or create anxiety. But
this actually is a perfect segue from the last social connections piece, because I think that you can go even deeper into how a chronic illness, being diagnosed with a chronic illness, can make you feel isolated. A patient feels like they're the only one dealing with it. They're the only one that has to follow this diet. How to bring in family members to support that and involve them with exercise, family exercises, peer friend groups, all of those things. But I think, again, it's the screening tools, I think, that are the most important to be able to assess how the patient is managing their chronic illness, no matter what it is. I know we're talking about diabetes, but I ask them 2 questions. What's the hardest thing right now? And what do you fear the most? And when I get answers from those, that can change at any visit, from one thing to the next. So that's what I like to do.
Very practical. And Sandy.
New York is very fast-paced, very high stress, and a lot of the people who I speak with are very ambitious and don't have any plans of slowing down. So the stress is always going to be there, and that big question is, what are you doing to manage that stress? Because none of that is ever going to change. And a lot of times with patients, and even myself and my peers, one of the questions that I ask is, what are you doing to manage your stress? And people may realize that they're not actually doing anything to combat it. And that's what leads to things like burnout. So just asking, what are you doing, what makes you happy and relaxes you, is definitely a great place to start.
So I'm going to disagree with the New York being stressful thing. I did a fellowship many years ago in Washington, D.C., and when I got there, someone told me the way you define Washington, D.C. is the stress of the North with the speed of the South, which is a really bad combination. But yeah, it was more stressful. You know, you're a New Yorker. You want your slice of pizza in about 30 seconds. You know, not like 5 minutes. Forget it. You're like stressed out by then. So, Michelle.
So one of my favorite things to do with patients, and by the way, those are great answers, and I love hearing about my patients' coping mechanisms for stress. They're sometimes really surprising and great. But I actually like to walk my patient through a breathing exercise during the visit, which is something that they can kind of take home and practice. And again, as with many things that I do, there's a selfish angle because I'm stressed during like a busy clinic day. And so I'll teach the patient, there's so many variations on different breathing techniques. My personal favorite is the 4-7-8 breath count. So it's you're breathing in, slowly inhaling for a count of 4, holding your breath for 7, or some people may not be able to hold it that long, so you can modify, but holding your breath at the top, and then breathing out through your mouth slowly for a count of 8. Even just talking about it kind of helps me feel more relaxed, and I love doing it with patients, and they enjoy it as well and can take it home and practice.
Great. We're flying here, by the way, I want you to know. I've completely stressed all 3 of them out, but they're doing great.
So if you can all do the breathing exercise for us, that'd be good.
All right, the last pillar here is the risky substances. So it's about alcohol, tobacco, recreational drugs, which are increasingly becoming legal, and how they might affect your diabetes. And one of the individuals on the panel has type 2 diabetes, and I remember her early on expressing, wow, this is really of great importance that folks with diabetes, they really want to know, can we drink a little bit? Is it okay to have a glass of wine? That this is a real relevant thing. So we don't have as much robust evidence on other things, but we have a fair amount. And some concepts are shown here. I'll put Sandy on the spot and have her start about something that she sees here that you might want to talk about.
So one of the things that I think is important is building that relationship with the patients where they feel comfortable sharing with you. So when I was earlier in my career, which again was just a few years, I remember just straight up asking, how much do you drink, do you smoke? And the answer that I get compared to me saying, I'm worried about your liver enzymes, like we can work together, I'm not gonna say don't drink anything, how much do you drink is very different. It went from somebody saying that they take a shot a week to that same person a little bit later saying, actually it's more like 3 shots a day. So building that connection where they feel comfortable and know that you're on their side and not just gonna say, that's bad for you, don't do it, is definitely gonna help patients feel more comfortable sharing.
Okay, Dr. McMackin.
Yeah, definitely agree with a non-judgmental approach, and of course meeting people. And you know, we all know that for people to make a lifestyle change, they have to feel like something positive is going to come out of it, that they're going in a way that's actually going to help them feel better. But I was struck recently by, in addition to all the data that you shared, Dr. Frades, about alcohol and diabetes, the other angle, of course, is to think about what we formerly called fatty liver, which is now has the name MASLD, metabolic associated steatotic liver dysfunction. It's a mouthful. But when most people who are living with type 2 diabetes have some element of MASLD. And so we know that when you actually consume alcohol in that setting, it can actually combine with the effects of insulin resistance and their pre-existing steatosis in the liver. And so it is really important to think about limiting alcohol and helping our patients move in the direction of reducing or avoiding.
Thank you. We went through those very quickly, I must say. So, I'm going to give each of our superstars here a couple of moments, 2 minutes each, to give you their thoughts about how you might want to bring this stuff into your practice. Jonathan, why don't you go first?
Well, I'll springboard off of the last pillar into what I didn't get in my training 28 years ago, and that was how to talk to patients using motivational interviewing, how to talk with patients using shared decision-making and techniques like the OARS technique. If I'm saying things that you have not heard about, go out and learn about those things or demand that it gets put in your educational curriculum. Those are the techniques that allowed me to begin to have these conversations within all pillars, truly. So where the rubber meets the road, we can have all the evidence that we want and read it and believe it ourselves, but if we can't connect with the patient sitting in front of us, it's never going to reach them. And that's got to happen, it's got to be followed up, and it's got to be sustained. So I'll leave it with that.
It's a terrific point, because for those of you who do pursue lifestyle medicine or get involved, it's not just the 6 pillars. Really, the unstated pillar 7 is behavior change and, health behavior, assessing readiness to change, using models like the trans-theoretical model, motivational interviewing, cognitive behavioral therapy, all these ways, coaching and support models to get people to actually have sustained change. And we will get into that in the guideline. So Sandy, your concluding thoughts?
So fun fact, it can take people anywhere from 21 to 152 days to make a behavior change. So it's not easy. It's something that you have to keep working on. And just like Jonathan was saying, I like to use SMART goals to try to identify what is the most important thing to my patient. So especially elderly patients, I feel like a lot of times they're like, oh, I'm already been doing it this way. I have diabetes. I've accepted it. We're done. I'm not going to change what I'm doing. But asking them what's important to them. Do they want to be there longer for their grandkids? Do they want to be able to be more mobile or have that functional independence even 10 years down the line? And identifying what that specific thing is that's important to them can really help motivate them to make that change, because it's not a sprint, it's a long run that they're in for.
It's a marathon, yes, okay. Lifestyle change is a marathon. All right, Michelle.
I think one of the things that I realized is that early on I was trying to do a lot of sort of telling the patient what I recommended, and that often does not work. And so I think, Dr. Frates, you're someone who says this all the time, that the patient is the expert in their own life. And I say that to myself almost with every single patient that I see, because if I'm sitting there dying to say, I want you to do this, I often just say, just stop and ask them, what do you think you can work on? And what are you ready to work on? What kind of comes to mind? And it's really great, because they'll often have really good ideas that I would never have thought of, because they're the expert.
Mm-hmm. Great. Well, we have actually made up quite a bit of time. So I think we have time for just a couple of questions. So please come to the mic if you're going to do it. So you can all pat yourselves on the back for lightning round, folks. They were good. This is a good panel, I got to tell you. These folks are good. All right, so yes, first question.
Hi, I'm Dr. Viswanathan. I'm chair of psychiatry at Downstate, and thank you for organizing this very important conference. Dr. Frates, I'm also the president of the American Psychiatric Association. I just became president 2 days ago. Thank you. And guess what? Every president gets to choose a theme. And the theme I have chosen for my presidency is lifestyle for positive mental and physical health.
All right.
So I look forward to working with your organization and other organizations. I have a couple of questions which are kind of more scientific. One is on timing of exercise. I run in the morning before breakfast because I can fit it in like Dr. Rosenfeld does. And I think, probably it helps burn down the fat. But on the other hand, I have seen evidence that people, there are two things. One is if you run after eating, obviously it keeps the blood sugar low. And I have also seen literature that people who exercise in the evening, these are correlational studies, who exercise in the evening live longer than people who exercise in the morning. So any comments?
I can answer that because I delve into this literature, and basically you can find a study to support anything you just said. It's a crapshoot out there. I think the common theme is that exercising fasted is a bad idea if you're going to do anything significant. So you want to have some carbohydrates on board, simple carbohydrates. You can eat some dates or figs or something, and you want to have ideally some essential amino acids, which get into the bloodstream very quickly. There are things you can get, has a little caffeine in there. But as far as time of day, it's a myth that if you do it on an empty stomach, you're going to lose more weight, or if you do it in the evening, you're going to gain weight or have trouble sleeping. So I think it's whenever you want, just don't do it fasted. If you're going to be doing it more than, say, 60 to 90 minutes, refuel a little bit with some carbohydrates. But beyond that, unless anyone else knows of any hardcore evidence, I'm not aware of it.
The best time is when you're willing to do it.
That's it.
Absolutely.
When it fits in your day.
Yep.
Yeah. The second question has to do with the processed food. And Dr. Bassin, I used to think like what you did till about a half an hour ago. Yeah. I thought that as long, as you're eating other healthy foods, because the problem with the processed food is, whether the evidence is on the processed food, or is it simply because that's a proxy for your not eating healthy food? So the question is whether you are eating, as long as you're getting your fiber and plant-based, cruciferous vegetables and all, is it okay to go on to processed foods? But then the problem is, one is the research which was showing the mortality associated with processed food. Usually in research, they try to statistically adjust for your not eating healthy foods. The other thing is, as Dr. Rosenfeld mentioned, sodium is a #1 killer, and many processed foods, are high in sodium and also high in sugar, and also, advanced glycation end products because they're also fried. So obviously, we cannot totally be without any enjoyment, but are there dangers associated with going, beyond a little bit of a processed food? Can you comment on it?
Sandy, you've, I think, done the most research on this. Go ahead.
I actually did a lecture or a session for high school students where I showed them a 20-ounce can of soda and then had the physical amount of sugar that was in there by tablespoons in a box next to it. And the kids were all completely disgusted and said, I don't want that, I would never have it. And of course, half of them accepted my seltzer alternative, and most of them still wanted soda. So when you see the actual amount of sodium and sugar in something, you realize, I would never willingly want to go eat that. But when it's packaged in these frozen foods, you don't taste it as much, and it's more of it being there for a preservative. So trying to avoid it as much as possible is definitely great, and the more fiber that you have in your diet, you just don't have room or feel hungry to add those processed foods. But ACLM has a great spectrum of your diet, and you start with the SAD American diet, and then over here we have fully whole food plant-based, and everybody is on that spectrum, and everyone can choose where on that spectrum they want to stop. So I think saying a hard and fast, only this much processed food isn't really the best for patients because they know their life and they have to kind of pick where on that spectrum do I want to be.
Great. And especially for young kids now, and it's worse with Hispanic and Black children. They're eating like 80% ultra-processed foods, and the obesity is through the roof. We have fortunately saved our last and most important question for last, right before lunch, so go ahead.
All right, good afternoon, everybody. My name is Rotasha Atkins-Jones, and I'm a volunteer for Plant Power Metro New York. I really have to say this has been an awesome conference thus far, but I have a challenging question for each one of you panelists. This is an all-day conference, and we've been sitting too long. So how can we get all this incredible information to grow ourselves, but spend less time sitting? So we need to integrate more breaks and be able to move, because we all are talking about how important movement is. So that is my question, and I love what you guys are doing. Thank you.
Thank you.
Soleus push-ups.
Go ahead, yeah, solely as push-ups, he just said it. But you're gonna have a lot of opportunity to do some walking between all those tables in the networking session, and getting your lunch is a break. But
I've walked
I don't
4
know, any
miles
other,
since y'all
any
started. I have
thoughts
11,000 plus steps since this
on,
began. 'Cause I stood
Michelle,
back
you
there
have
walking.
thoughts on ways to secretly get the exercise
Well,
in
you said
while
you have
you're sitting there?
11,000 steps since
Yes,
this conference
'cause I was
began.
walking up and
Yeah.
down back
Perfect.
there while you guys
There's
were
nothing else to say. That's
teaching
amazing.
us.
Yeah.
There you go.
It's a good question, and we've tried to, we had the little break in there before, but if we had too many breaks, we'd have no conference. So anybody is free. I think, as Dr. Frady suggested, you can stand up anytime you want. You can twist and turn. Just don't do it if you have osteoporosis. And,
There are
hug your neighbor.
4 gyms right there,
Build a social
four
connection.
staircases right there.
And most importantly, we're going to go eat some lunch.